Dear Gary, could you briefly introduce yourself to our audience?
Sure. So my name's Gary Lemack. I'm a professor of urology and neurology at the University of Texas Southwestern Medical Center in Dallas. I'm a program director of our urology program and also the program director of our female pelvic medicine and reconstructive surgery program at UT Southwestern in Dallas.
Okay, how to evaluate and survey neurourology and dysfunction?
So, how we evaluate patients that have neurologic disorders and bladder dysfunction. And there's not actually one concrete answer to this. And the reason is because you can't really lump everybody together. We found over the years that there are different categories of neurological patients that require different surveillance. So, for example, what we've discovered over the years in taking care of hundreds of MS patients with multiple sclerosis, that they probably require a different evaluation and follow-up algorithm than somebody who's at high risk. For example, patients with spina bifida, patients with high spinal cord injury lesions that require a very different algorithm. Those patients were a little more heavy-handed, more frequent surveillance of their upper tracts, and maybe even more frequent urodynamic studies. Whereas in MS patients, we've worked on an algorithm to say, when do we need to do that? And what's the appropriate time to do that? And maybe not everybody requires evaluations as intensive up front. So what we've learned over the years is that we really need to sort of separate them and not group them all together.
So in your opinion, what's the best survey method to this kind of dysfunction?
The best surveillance
Yes.
for neurologic? So I will say that, for example, for patients who are at high risk, high spinal cord injury, patients who have known bad bladders when they're initially seen, poorly compliant bladders and so forth, that at the very least they should be getting imaging every 1 to 2 years of their kidneys, typically with renal ultrasound, sometimes with renal scans, serum monitoring of kidney function. And we know that in this population that may not have the same muscle mass, that serum creatinine is not always the best monitor, so there may be other ways we could do that. And perhaps periodic urodynamic testing, depending on what their baseline urodynamics show. In MS patients, for example, that are stable, that symptoms are unchanged, that aren't getting infections, I don't necessarily get urodynamics. I don't necessarily think they're imperative early on, and only get those if symptoms change. Similarly, upper tract management, upper tract assessment, typically not at baseline, unless they're a high-risk population. So maybe men with MS would be at higher risk. Maybe those patients who have a high residual urine at baseline or a lot of symptoms, I'll probably be a little more heavy-handed in those folks.
So in this way, you may think the ongoing surveillance should be offered to our patients with TM and LUTS.
So in transverse myelitis patients and lower urinary tract symptoms is something we've seen quite a bit of and reported on in the past. For those who don't know, transverse myelitis, it has a lot of overlap with multiple sclerosis. Sometimes they're not correctly diagnosed, but similar in terms of the neurologic patterns. But we have found in those patients that they had a surprisingly high amount of lower urinary tract symptoms and urodynamic abnormalities. So in those patients, certainly we're a little more aggressive about evaluating them with urodynamics up front because it's a little unpredictable based on their symptoms what we're going to see on urodynamics. So in that select group, we have been a little more surprised what we've seen, especially in the male patients with transverse myelitis.
Okay, so is SPC an effective bladder management in patients with NGB?
So it's a good question. We've talked about this in the past at our meeting. So the question is suprapubic catheterization appropriate? And I will say this, that in an appropriate selected patient, my feeling is, yeah, I think it is appropriate. But you've got to be very careful about it. And what do I mean? Older patients, those who have really mobility challenged, those who have significant incontinence and just are really troubled by that, and it's clearly affecting their quality of life. Their hygiene is poor, they're having skin breakdown. Those patients, I think, will benefit. Now, you don't tell any of them that they're not going to get bladder infections. They certainly very well may with an indwelling catheter. You do have to carefully explain to them that even though their urine may look cloudy And if a urine is sent, it may show an infection, but that doesn't mean you always treat it. So you need to educate them about when and when not to treat. But in carefully selected patients, I think it's appropriate. We actually did a survey and published this last year of just about 100 of our patients that had suprapubic catheters that were debilitated, had mobility challenges, and we asked them if it improved their quality of life. And nearly 90% said it did. So it's all about selecting the right patient. But in that patient population, I think it is appropriate.
Okay, so now you have any advances in urologic dysfunction?
So in terms of, I think we have made a lot of headway. I think we are being more careful about who we select for evaluation. If you just look at sort of morbidity and mortality of patients, for example, with spinal cord injury, we've made huge impacts. And these impacts have been going on for the last 10 years. The death rate due to urologic dysfunction has changed significantly. And so the use of antibiotics, the use of serial imaging, the use of intermittent catheterization has had significant improvements. But specifically, I think what we've learned is that one size does not fit all when it comes to evaluating and treating these patients, and you need to treat them on an individual basis. And that's maybe the one thing we've learned. You can't just use one number from urodynamics and say, this is the group we need to focus in on. We need to be very selective and individual in terms of how we treat the patients.
Okay, so you have anything else you would like to share with our readers in this field?
So I would just say that this is a big patient population that for urologists, it's something we see a lot of. Sometimes we're frustrated. We don't feel like we know what we need to do. We have tools to try to help sort that out. And I would say that sometimes there is no intervention and you need to have that discussion with patients, but many times there are things that we can do to help them and improve or stabilize their quality of life. So evaluate them, talk to them appropriately, if appropriate, have an intervention. But we've learned over the years you can continue to improve their quality of life, which is really what they're after. And in those individual patients that are at higher risk for really more significant problems, identify them early on, be more cognizant about getting the evaluations periodically. But that's a select group and a rather small group. So that's what I would say.
That's